I am Valentin Fuster from New York. I am editor-in-chief of the Journal of the American College of Cardiology, or JACC, and it is a pleasure to introduce today a new initiative of JACC. It's a pathway of a patient. The title will be JACC Patient Pathways, which we will be presenting from time to time and will be published in the journal. Well, first of all, I'd like to give thanks to the participants of this particular first patient presented today, and I'd like to introduce them. Dr. Chandrashekhar, who is the Chief of Cardiology at the Minneapolis VA Hospital in Minnesota, and he's actually the editor of JACC Cardiovascular Imaging. Then we have Dr. Blair D, who is a cardiologist from the Bozeman-Deaconess Health in Bozeman in Montana. We have Dr. Julia Grapsa, who actually is going to make the presentation of the case. She's consultant cardiologist at the Guy's and St. Thomas Trust in London, United Kingdom, and she's actually the editor of JACC case reports. And then we have Dr. Michael Mack, who is medical director of cardiothoracic surgery for the Baylor Scott and White Health and the chairman of the Baylor Scott and White and the Heart Hospital in Payano Research in Texas. And then we have Professor Bernard Prendergast, who is the director of the Cardiac Structural Interventional Program at Guy's and St. Thomas Trust in London. Now, and then we will have also a surgeon, Dr. Christopher Blood, who is going to be also present on a video setup. So this is the story. We are going to be presenting a patient, and we have a number of people which will express opinions. This is a complex case. And Julia has put in a lot of effort to make this case an interesting one. So without any more information or introductions, let me ask Julia to begin to present the case.
Okay, so I hope that you can hear me all okay. So thank you very much, Dr. Fuster. Let's start from the history of presentation. A 19-year-old female patient presenting to the emergency department with 5 days vomiting, fevers, and intermittent abdominal pain, myalgia, and weakness. And from her past medical history, she came to the UK from Brazil 6 weeks ago. Her partner witnessed that she was complaining of palpitations occasionally and joint pains. On admission, if you see her blood pressure was low, she was hypotensive with a blood pressure of 86 over 49 millimeters per mercury, and she was profoundly tachycardic with heart rate 140 over to 150 beats per minute in sinus tachycardia. Saturation was 94% on room air, and her GCS, actually she was neurologically intact with the GCS 15 out of 15. So moving to the ECG on admission, this demonstrates sinus tachycardia of 140, 150 beats per minute. And then we are moving to the next slide, which is the chest X-ray on admission.
Let me ask the first question here. Chandra, have you ever seen a chest X-ray like this, or you see such chest X-rays every day like this?
I was hoping you would ask somebody else. No, I've never seen this kind of an X-ray, and this is the kind of X-ray which makes your heart sink to your boots.
Well, Dr. Michael Mack, you're a surgeon. Have you seen a chest X-ray like this?
Yes, I have, but it's never been in a good situation, and most of the time it does not end well.
But when you enter, can you see the heart with this in the front?
No, I cannot. It's total consolidation of the chest cavity.
Interesting. Okay, Julia, you can continue.
So on presentation, she was in extremis, and she was hypoxic, acidotic, hypotensive, and therefore the intensive care team assessed the patient, and she was candidate for ECMO retrieval in emergency department. And here you can see her gas actually during her stay in the emergency department. Subsequently, we got in the meanwhile the blood results, and you can see that she's profoundly septic with a white cell count 26.1, CRP 360, platelets are on the low side 112, and she has acute renal injury with urea of 12.1 and creatinine 151. And here we have the normal range in order to make sure that people understand the derangement. And also we did a full screening, that because initially we suspected that the patient may have been COVID positive, but eventually she was COVID negative, but she had blood cultures positive for Staph aureus.
Okay, let me just stop here, because this really something we need some thinking. And one of the thinkers is Dr. Prendergast. He's he's an interventionalist and actually a real expert on infective endocarditis and sepsis and so forth. Dr. Prendergast, what is your reaction to this?
Thank you, Dr. Fuster. I mean, firstly, this lady is in extremis and incredibly sick. You don't need to be a doctor to look at that chest X-ray and realize the gravity of the situation. I'm very, very pleased that the doctors took blood cultures so swiftly, because particularly at the time of this lady's presentation, in the middle of the COVID pandemic, and having arrived recently from Brazil, the instinct would have been to treat her as a COVID patient regardless of any differential diagnosis. And the fact that Staph aureus grew so quickly was a very important clue, a very important trigger to think about alternative diagnoses, including infective endocarditis. And we have indeed seen many late presenters where this important diagnosis has been overlooked in the era of COVID.
Dr. Prendergast, the fact that this Staphylococcus aureus positive, where do you think is coming from?
Well, that's also a very important question, absolutely. And it's very unusual in a 19-year-old young lady to present de novo with staph sepsis. You might see it in an older patient with skin problems. You might see it in a patient with lines in situ, but it's a very unusual organism. I don't think you told us, Julia, she's not an IV drug addict, presumably.
No, she's not. But on questioning here, the only suspicion that we had is that 6 months ago, she underwent a dental procedure in this small village in Brazil that she was coming from.
So an important clue from the history, but again, it wouldn't lead you to consider Staphylococcus. So it's already an unusual case.
Okay, well, there's a lot of excitement here to see what it is. Let's move into next, Julia.
So here my question is, what would you do next, Dr. Fuster?
Well, what I will do next is to ask Dr. Earp.
Well, I think I have a hard time removing myself from the environment I work in. She probably would have gotten CT scan from stem to stern in our emergency room. But for me in particular, I'm a little bit shocked at or intrigued at the level of tachycardia compared to her level of acidemia. It may be the hypoxemia that's made her so tachycardic, but it makes me wonder if there's not something else contributing to her hypotension and hemodynamic collapse. So since we all do what we do, I would get an echo.
Dr. Prendergast, what do you do?
I would definitely do an echocardiogram, and I'd be doing that in the ED or the ER, because it's going to determine the next steps. Okay,
Julia, let's see what you did.
So that's correct, I would say. First, the patient, because she was an ECMO retrieval and they were in a rush to get here to intensive care unit, she underwent a CT body. And then what we demonstrate actually is that she had dense consolidation of both lungs bilaterally, that the airways were completely collapsed. And also on the right, you can see that there were suspected subdural hemorrhage As it was described, there was a small linear area of high density in the right parafalcine region. Differentials include a small subdural hematoma or a small thrombus within a tributary in the superior sagittal sinus. The detailed report from the CT scan that confirmed that the patient
Julia,
did not...
Julia, let me stop for a moment. I'd like to go back to the previous one, please. Excellent. Okay, Chandra, you are an expert in this field, but I have two questions for you. I still wonder why an echo was not done first on somebody who presents with sepsis, and the possibility of infective endocarditis is very high. That's the first question. I have to be convinced about. And the second question is, what do you see here?
Yeah, no, those are excellent points. So on the bedside, as we go through this, a number of things fly through your mind, right? So when I go back and interpret this in the context of the X-ray is completely white out. The mediastinum is not shifted, so suggesting both lungs are involved in a similar amount of pathology. I see some air bronchograms, but there is no aeration anywhere in the lung. There are only few conditions that can do that. And obviously, if you are dealing with massive consolidation on both sides, they would probably go the CT route. If they are thinking pulmonary edema, then it would be the echo route. I personally would go down the echo route as the next step. But having done this CT, this is really impressive, right? The whole lung, both sides, they look like liver. And in the old literature, there's this term called hepatization of the lung. And that was described in the intermediate stages of pneumonia. This is something like that. And I don't see much here that can provide aeration. And it is curious that on admission, her SATs were normal, 94. So I have some loose ends here, but this looks like dense consolidation or pulmonary edema. And I would go down the echo route. The brain scan, I'm not completely convinced there is a bleed there, but you can see some gray matter, white matter in the lower half of the brain, shows the differentiation is going, but I'm sure the radiologist had access to many more cuts and they could window and level. So all in all, we are looking like a multi-system condition with severe involvement of lungs, probably a combination of pulmonary edema and consolidation. And I would be very interested in seeing the echo, especially with staff.
Okay, Julia.
So thank you very much, Chandra, because you're right. I'll explain the time difference between the two tests. This is the report from the CT scan, and the highlight here is that the patient has also embolic events, and she has bilateral renal and splenic infarcts. And as we discussed that she has suspected subdural hemorrhage, the lungs are collapsed, there is no pulmonary embolism, and there is bilateral periportal edema. Now, in the meanwhile, though, just we get another blood test that demonstrates that the patient has gone into DIC, and her HP has dropped to 8, platelets to 50, and INR starts raising to 1.2. And then a repeat gas demonstrates lactate of 0.8, no profound change when compared to the initial gas. So here, I think we already discussed that, but I would like to focus again on what would you do next. Dr. Fuster?
Let me ask my colleagues. I have lots of questions here. All right.
Would be
Dr. Prendergast, is this disseminated intravascular coagulation? And if it is, why? Can you tell us? I want to be sure that I understand the case.
Well, I'm not a hematologist, I emphasize, but my understanding is that you need to see evidence of fibrin degradation products. You need to see consumption of blood products, so a reduction in fibrinogen, which is not really apparent. And you need to see thrombocytopenia, which is there. So it's not fully established DIC as I interpret it, but we are seeing this at a very early stage of the natural history of this illness.
Thank you. Dr. Erb, what do you think about this picture? It doesn't look too good.
No, it doesn't. When she came in, she was already thrombocytopenic, which is, I mean, the combination of leukocytosis and thrombocytopenia really speaks to bacterial sepsis. One could look at this and say, you know, this is further progression of sepsis-associated thrombocytopenia without frank DIC.
Okay, Dr. Mack, Dr. Michael Mack, you're a great surgeon. Is anything crossing your mind at this point? Or you think this is for somebody else, this whole case?
No, I think that it's only a matter of time, but this case is going to make it my way in all likelihood. I agree that this is early stages of DIC on the basis of thrombocytopenia and a low normal fibrinogen level. It's not full blown, but it's headed in this direction. I was unclear at the presentation to begin with whether the patient went directly to ECMO without being mechanically ventilated first and intubated. I didn't see that on any of the any of the imaging studies, an endotracheal tube in place. So I thought that that was an interesting aspect of this, but clearly this patient has septic. We have evidence of embolization. So in all likelihood, this is endocarditis, and therefore she, in all likelihood, will end up very soon in the operating room.
Michael, you brought a point, and I like to be educated. The role of ECMO in a patient with sepsis. Is this, it scares me.
So I would say that we have seen a dramatic increase in utilization of ECMO over the past couple of years. And we have seen very many situations in which patients were in dire straits that we previously were reluctant to use ECMO and have actually found beneficial survival, specifically VV ECMO with respiratory causes. Now, we also saw a reluctance to use ECMO at the beginning of COVID on the basis of not only futility, but also concerns about additional spread within the institutions. But we've actually found that in advanced degrees of ARDS with COVID, the survival to discharge off ECMO exceeds 50%. So the COVID pandemic has actually further increased the use of ECMO overall, including in septic situations.
Yeah, thank you very much. I think this is a very good point. Chandra, we are getting into a patient, and I don't have an echo. I thought echo was discovered as a simple technique to know where you are, and we see all sorts of things here, very sophisticated. But where is the echo people?
I'm waiting for that. I would be very eager to see what's the source of this sepsis and why is she so hemodynamically tenuous. The low hemoglobin also is very interesting. Presumably she is not bleeding, but I wonder why the hemoglobin was low, suggesting some chronicity. Oh, there it comes. This is our favorite part.
He wanted to impress you now.
Here is the favorite part. Okay.
And
so
I want just to mention that before I give you the control, Chandra, for the slides, that the distance, the time difference between the ECMO, the CT, and the echo were just an hour away. So just to clarify that. So now, Chandra, please take over the slides and to discuss the echo.
Okay, awesome. So on the left side, you have a parasternal long axis view. Let me go back to the previous one. Okay, so here is the parasternal long axis view, and let's start with that one first. So you can see here is the aorta, aortic valve, septum, posterior lateral wall, anterior mitral leaflet, posterior mitral leaflet, left atrium. The first thing that strikes you is something is bouncing around here in the back, and that obviously shouldn't be there. This posterior mitral leaflet is thick. The anterior mitral leaflet is not thick, suggesting this was probably a normal valve to start with, and something that should not be there is here. And common, the two things you would think about is a tone, pap muscle, or a leaflet, or a cord, or a vegetation. The good news is the anterior mitral leaflet is not involved. There is the trigone area, which is like one of the red flags, that's not involved. The ventricle is not dilated. The atrium is not dilated. The function is good. So that raises the question that this is not a chronic process, and probably we are dealing with an acute MR in a person who didn't have that before. Let's see what the color Doppler shows here. So here is the color Doppler, and straight away you can see something that is very concerning. So there is MR, but there are two jets. One is going this way and one is going this way. And when you have jets going in multiple directions, it often means it's a complicated valve leakage, probably because of destruction or in areas where you are involving more than one edge of the leaflet. And then again, acute MR has this characteristic that it doesn't look very impressive when you look at it. The jet doesn't look very impressive because the hemodynamics don't allow prolonged jets. And that again suggests that we are dealing with a very high risk situation. Let's see what this shows. Okay, again, there is a leakage here, but as I said, it doesn't really look very impressive, but we saw that in the previous jet. Here is the tricuspid or the right-sided thing. So you can see this is the LV. Here is the vegetation. It's kind of oddly on the septum, which is not a common part. Here you can see parts of the tricuspid valve, and this is an odd area for the leaf, for the vegetation. You can see the same one here also. Here you get a sense sometimes, is it a papillary head or a vegetation? But the leaflets themselves on the tricuspid valve don't have anything, and we'll see if there's a leak down the road, if there is other echo. You can see the vegetation here. This gives you a little bit of anatomic orientation. So LV, RV, and posterior leaflet, anterior leaflet. And you can see the posterior leaflet here may be torn. And this is in the medial, posterior medial commissural area of the valve. And then there is also a vegetation in the other part of the posterior leaflet. So I would say predominantly posterior leaflet involvement. There may be a torn area, and there is significant acute MR associated with the vegetation on the right side. Back to you, Julia.
Thank you very much, Chandra. So now we have this dilemma that we will discuss. Against surgery, we have the subdural hemorrhage and the DIC. And in favor of surgery, we have a young girl who suffers from Staph aureus bacteremia, has increasing vegetations on mitral valve, and she also has evidence of embolism, splenic and renal. So, Dr. Fuster, would you like to take over?
Yeah, thank you very much. Well, let's dissect all these options. And I want to ask Michael Mack first. Michael, over the years, we experienced a number of patients with infective endocarditis. And whatever was going on in the brain, whether it was a thromboemboli or whether it was a hemorrhage, I was always told by the surgeons, please, let's wait. And this is over the years. I remember patients I had at Mayo Clinic, which actually was the thinking in the 1960s. I faced the same thing when we were in Boston, the Mass General, with some cases in which with infective endocarditis, we were told, wait. More recently, I have seen patients operated in the middle of a problem like this. First of all, let me ask you, Michael, what is your feeling over the years about this aspect of the brain in a patient which actually may require surgery? What's your thinking?
So you are correct that there has always been hesitation about proceeding to surgery in patients with endocarditis that have had brain lesions or a stroke. The concern is converting a non-hemorrhagic stroke to a hemorrhagic one and worsening the situation. That hesitancy has progressively declined over the years, and we have become much more aggressive early in terms of intervening because we have learned that the longer you wait, the worse things get. A lot of this has associated with the IV drug epidemic, in which a lot of these patients do have septic emboli to the brain, and that we have learned that you can intervene earlier without advancing neurologic deficit and further hemorrhage. As a matter of fact, there is under consideration a trial in the cardiothoracic surgery network of timing of endocarditis in patients, the timing of surgery in endocarditis in patients that have had a stroke. And we're having trouble getting it off the ground because everybody is convinced that early surgery is now the right answer rather than delaying. In this patient's particular interest, I would not have too much concerns here in view of the fact that the patient's already on ECMO, already anticoagulated, has small subdurals, which is different than a brain infarct. And if those happen to worsen, those always can be managed.
Thank you. Second question, Dr. Prendergast, is for you. I always get scared when I hear Staph aureus and any possibility of infective endocarditis. And the reason that it scares me is because, at least in my experience, this penetrates into the tissues. And you ask a surgeon to do a monumental work, and that is not only to address the valve, but to address whatever is surrounding the valve with all the complications. Now, what is your reaction to Staph aureus in a patient like this, for example, as it affecting the valve?
Well, I share your concerns every time I hear about staphylococcal septicemia, Dr. Fuster, absolutely. Particularly in a patient like this who is critically unwell, in whom we have now demonstrated significant valve disease and hemodynamic decompensation and impending multi-organ failure. So I would be urging my surgeons to take on this patient immediately. And I think Michael Mack won't disagree that this patient should be in the OR within 2 or 3 hours, ideally. Equally, the scale of the surgical challenge is not trivial. This is not a simple vegetectomy and a valve repair. It needs an experienced surgeon and it needs a good look around the heart to make sure there's nothing further that needs to be done.
Okay, well, you're quite right, actually. What you are saying is there are no options here.
Exactly. We used to have an expression in the UK, I'm not sure if it was the same in the US, but nobody should die without the life-saving benefits of cardiac surgery. This is a case in point.
Very good point. I'm not sure if the United States or not, but the legal issues sometimes appear in front of us in one way or another. I don't want to get into this, but it's not so simple. And let me tell you why. Because in the United States, the surgeons are rated, the institutions are rated, and they look first at mortality. And, you know, you always say, well, no problem, they're all adjustments. Well, the surgeons don't like to hear all these adjustments because at the very end, things can be difficult. Michael, maybe you have been in these committees, and at least I have sensed on the surgeons sometimes a reluctance to go into a patient that has more than a 50% mortality.
No, you're absolutely right, Valentin. There is the concern that public reporting and of outcomes has created risk-averse behavior in surgeons. And I think that is a fact of life that we all have to deal with. The case here, however, is I think endocarditis is different because everybody realizes it's a lethal disease when untreated. And this is a 19-year-old previously healthy female. So I would say that the overwhelming majority of surgeons would be willing to take this case on.
Thank you. Dr. Erb, we hear a lot about the size of vegetations, you know. I think I may be correct or maybe not, Chandra, about, I think it's about 1 centimeter or is that correct?
Yeah, 10 millimeters or more. Yeah.
Yeah, and then you have to move on.
Correct.
Or perhaps when you have a previous embolism already, you have to move on and so forth. Dr. Erb, is this, this has been, you have a lot of experience with this kind of patients. It has been always a driving force to move into surgery when you have just patient perhaps much less sick, but with the vegetations that we are talking about.
Yes, it is. And this is a high-risk vegetation. Estimating its size, it exceeds 1 centimeter. It's freely mobile, and she already has evidence of previous systemic embolization. So I would consider that a high-risk vegetation to put into the formula to push towards surgery. The rest of it is really overwhelming infection, obviously based on the destruction in her heart, and the organism itself, which is one of the most destructive organisms with endocarditis, and add to that heart failure. She had every reason to proceed directly to the operating room.
Okay, Julia, what did you do? Did you ask a surgeon to move fast or you send the patient home? What did you decide?
Was actually that the surgical team and us as cardiologists, including Professor Prendergast, we wanted for the patient to go immediately to theaters. The critical care unit, they were slightly reluctant and they were suggesting, of course, to give few hours maybe for the DIC to correct. But definitely here we have the video of Dr. Christopher Blouth that you will see. And he explains why he decided to take the patients to theaters.
Dr. Blouth, we are dealing with a case of a 19-year-old young lady, and she presented to us with in cardiogenic shock. She had, as you remember, a white X-ray. She had the Staph aureus endocarditis with multiple vegetation on the mitral valve, but she developed quite quickly DIC, and she had small subdural hemorrhages and the CT scan. What led you practically to take her to theaters?
Well, 3 things really. Firstly, when I was training in surgery, we were always taught never to let the sun go down on pus. Secondly, we had echo evidence that her vegetations were increasing in size. And then she had already embolized, so we knew there was a danger of further embolism. And on those grounds, it really seemed that there was nothing to gain by waiting, and that one should schedule her operation at the earliest opportunity.
Okay,
Great.
so what happened?
And then she was taken indeed for surgery. And so this was just to give the timing, 30 hours after the ECMO retrieval. And here, Chandra, I'm not sure if you want to discuss the echo slides.
Sure, happy to. So here you can see some echoes in the intraoperative environment. This is transesophageal echo. Here is the right side. As happens in these acute situations, sometimes you don't get absolutely textbook-like pictures. And so you have to stitch together a bunch of studies together. And here is a good example of what we are seeing. This is a view called the bicommissural view, which anatomically lays out. This is the P1, P3, and the AML is in the middle. And here you can see the size of the vegetation, a big vegetation flopping around on probably the P1 leaflet of the posterior mitral leaflet, and an equally big one on the P3 leaflet scallop of the posterior leaflet. And so we had some concern about how big the vegetations are, and here it is very clear it's a concerning size of a vegetation. Let's see what the color shows. There comes the color. And again, as you can see, what we saw even in the transthoracic echo, it's a complicated jet. There are at least 2 jets here. Most of the jet is coming where the P3 would be, which is like the posterior medial commissure. And there is a leak here also. Again, in acute MR, you don't see torrential leaks. And this is certainly fitting with what we saw before. Back to you, Julia.
So thank you very much, Chandra. And here we have the question, what would be the preferable surgical technique? I think we mentioned more or less before about the importance of having a senior surgeon, and Dr. Christopher Blouth is the most senior surgeon in our team. So Dr. Fuster?
Well, I don't think I can answer this question, but certainly Michael will.
So there's a couple basic principles of all surgery for endocarditis. And the first principle is you remove all infected tissue or tissue that's clearly grossly infected. And after you do that, then you see what you have left. You don't worry about what you're sacrificing in order to do it. You worry about putting it back together after you have debrided all the infected tissue. And that creates some very complex reconstructive situations. The second principle is you don't want to use any prosthetic material, if at all possible, because of the high likelihood of that material getting infected. And then you're dealing with a more complex situation ultimately, because it's hard to sterilize prosthetic material. Therefore, you want to repair rather than replace. You want to repair with sutures only rather than felt and other methods of bolstering your sutures in surgery. And if you need material to reconstruct areas then of either the valves or the chamber walls, then you would want to use bovine pericardium or another type of tissue rather than a prosthetic valve per se. And then the last principle is the situation you're in. And in this situation, you have a young patient in extremis, you want to save this life. And therefore, if you have to replace it, despite all the reasons I just said not to be able to get that patient out and come back and fight another day when they're in a more stable condition, that's what you would do. Whereas if it's another situation, you know, in a patient that's not as an extremis or a different age, you might take a different approach. So bottom line, cut out all the infected tissue, then look at what you have, and then reconstruct without prosthetic material.
Thank you. So what was done, Julia?
So moving in the intraoperative findings, because first of all, I was in theaters. I want to mention that I did all the echo scans that you see, and also I was in theaters looking at the operation. So on the left side, Dr. Blouth found infective destruction of the posterior medial commissure, infection at the leading edge of the posterior leaflet throughout its length. And also there was also some vegetation on the ventricular surface under the posterior leaflet. And on the right side, there was a good vegetation, good size vegetation at the tip of the papillary muscle supplying the commissure. So here we have also the surgical illustration. that on the left, which is a tricuspid valve, practically he had tricuspid prolapse after the vegetation removal, and this was corrected by suturing the leaflets together and a further suture to the cleft on the anterior leaflet. And on the right, which is the mitral valve, there was proline annuloplasty from trigone to trigone, and annuloplasty in 2 layers with a 2-0 proline suture. So I'm not sure if you have any comments here, and we have also the video of Dr. Blouth.
Michael, any comments?
No, I think that Dr. Blouth did exactly the right procedure here from this standpoint. I didn't address the tricuspid part of it. You know, it complicates things, adding a tricuspid procedure to it. However, again, it's the principle of removing all infected tissue, and the tricuspid valve is forgiving in this instance. This vegetation was at the tip of a papillary muscle below the leaflet level, and this valve would be very repairable. So I totally concur with the surgical decisions that were made here.
Great. So we're moving to the video that Dr. Blouth explains the technique and
the left atrium and looked at the mitral valve. There was destruction at the posterior medial commissure, which is in keeping with the Staph aureus organism. And there were quite a few vegetations along the leading edge of the posterior leaflet, and also on some on the ventricular surface. We obeyed the standard rules of surgery for endocarditis. So rule 1, the primary mission is to remove all infected material, see what's left, and see what one can do with it. Bearing in mind that it's always better to repair if one can. And in her case of being a very young woman, it seemed important to push the boat out and try particularly hard to do a repair. And the other consideration really in infective endocarditis is to try and avoid implanting any foreign material. So my aim and my practice over the past 20-odd years has been to try and limit the repair to using just proline suture without Teflon or any fabric-based prosthetic material. And that's what we set out to do. Bearing in mind that one has to take into consideration the risk of reoperation. So in this patient, the risk of reoperation in a young person is relatively low. There's likely to be a need for reoperation potentially with a slightly suboptimal result, but that would be preferable in her to giving her a prosthetic valve, particularly if she wants to raise a family and in terms of the risk of recurrence of endocarditis.
I have a question here. Can we stop for a moment?
yes.
Yeah, for Michael. Michael, I'm very impressed about a surgeon with a stethoscope. Can you tell us a little bit about it? That is a stethoscope and
You know, I've had that comment many times over the years. What are you doing with a stethoscope? You're a surgeon. You don't know how to use that thing. And I just remind people that I originally trained in internal medicine.
yeah, okay. It's just a thought. It was very impressive. Anyway, carry on, Julia.
So we have now the immediately post-op TE to see if the repairs were successful. Chandra, would you like to take over?
Yeah, sure. Okay. So here is the right side, here is the left side. You get a view of the right side. It's tough to say what's going on unless we have color here, which I suppose we'll see soon. And then you can see the anterior mitral leaflet is still completely uninvolved. And here comes the the money shot, I suppose. Yeah. So here is the left ventricle. Here is the repaired posterior mitral leaflet, and here is the anterior mitral leaflet. They are coapting beautifully. And if I have to guess, it will have no MR or trivial MR. Back to you, Julia.
Thank you very much, Chandra. So here now, after we demonstrate successful tricuspid and mitral repair, the question is, what are the challenges of open heart surgery on ECMO and DIC? Because we had an ongoing in-theaters collaboration with hematologists and ECMO physicians. Dr. Fuster?
Well, I think my first question actually is the question of what is the role today of the cardiologist versus the intensivist when you are talking about ECMO, DIC, and so forth. And I like to ask Dr. Earp. Dr. Earp, I work in intensive care in my early years and actually following all the post-op patients. I did this at Mayo Clinic. And frankly, today, the technology has advanced so much that I feel like a student, and I like to know how you feel when all these characters are start to talk about technologies that you have not been exposed.
But I don't think there's any question that this is a process that's in transition. You know, in the old days, we did it all because we were internists. We knew what DIC was. We managed it. And we were basically the intensivists, but that has really changed with the technology and the understandings and having the intensivist parked in the ICU 24/7. There is a movement afoot for there to be cardiovascular intensivists. In fact, we're interviewing a young man in a few months who has that role. So I completely agree with the new technologies and new understandings, new medicines, new antibiotics. It's really transitioning to cardiovascular intensivists and with general intensivists.
Dr. Prendergast, what do you think?
I agree entirely with Dr. Earp. I mean, we cannot be experts in every field, and the intensivists have so many tools to offer that we need to work with them rather than against them and recognize their independent expertise.
So Chandra, ECMO is very close to echo. It's just an MO except that HO. So
Yeah. So I mean, you're right, and I'm learning the hard way that I need to learn a lot more than what I think I knew. And I'm trying to spend more time learning about this, but it's invaluable. I mean, we see patients who we couldn't have got them out of the hospital in the past. Now we can do it with a significant amount of success, and especially whether it's oxygenation or oxygenation and control of their pressure. This is like a big advance.
okay, let's go to the real expert, Michael. The question was, what are the challenges of open heart surgery on ECMO and DIC?
So the challenge at this point, now that we've seen a TEE with a great surgical repair, is getting out of the operating room. And the getting out of the operating room is all associated with bleeding and with the correction of the DIC. Normally, in a situation like this, you are able to reverse the heparinization with protamine, but you cannot in this situation because the patient's on ECMO. So therefore, you're faced with continuing anticoagulation and DIC, both of which are not going to allow you to obtain hemostasis. Therefore, in this situation, you spend as much time as it takes to get the operative field as dry as possible. And then in this patient, you would end up packing the chest with laparoscopy sponges and large bandages and leaving the sternum open while you get to the patient to an ICU and get them further corrected. and then come back, hopefully, when you can get off of ECMO or at least corrected the intravascular coagulation. And in all likelihood, this requires more than one trip back to the operating room.
Thank you. So what happened post-op, Julia?
So you're right, because the patient had her chest open in theaters for 2 hours because she was bleeding. And there was a direct communication with the hematologist and the ECMO physician in theaters, giving platelets and plasma. And then after they made sure that she was not bleeding anymore, the chest was closed. So now we're going to the echo that it's post-operative day 2 that I will show you.
Okay, so let's see what the results were. Okay, there is a beautiful repair. You can see great coaptation of the valve. This is repaired, the posterior leaflet. The anterior leaflet, posterior leaflet are coapting beautifully at the place where they are supposed to. There is no leak. That's very, very, very impressive. And then the amount of opening and the way it's filling suggests that it's unlikely there are any gradients there. So this is a very, very impressive result. This is on the right side, and again, not much leakage there. So it's actually a beautiful tricuspid valve vegetation excision. So very impressive. Back to you, Julia.
Thank you very much, Chandra. And here we have a summary of the post-operative course and the antibiotics, practically starting with clindamycin on the initial presentation. And you see how when we switched to flucloxacillin and then the CRP dropped and her creatinine started to, she needed actually renal replacement therapy. Her creatinine started to correct gradually. It took a few weeks. But so practically 26th of January was the end of antibiotics. I remind you that she was admitted on the 12th of December and she was on VV ECMO for 3 days, DIC correct within 24 hours. An important finding is that one evening, one of the trainees in intensive care unit did an autoimmune screen and she was found to be positive for SLE. And that may explain practically the joint pains that she was describing at the beginning. So now on the next slide that you will see,
No,
this is the follow. Yes.
Excuse me, Julia. I'd
Yes.
like to ask, no, Dr. Prendergast, here's the situation. I think this is almost a miracle, frankly, if I look at the case from the first chest X-ray. The Chandra said that both lungs were consolidated. And here we are. So give us your present view of all of these, of the case.
Well, this is a miraculous save, but it's a tribute to early diagnosis, to the synergistic management by numerous specialist teams, intensive care, hematology, cardiology, and cardiac surgery working together for one young, unfortunate young lady. The intense antibiotic treatment is equally important, overseen by the microbiology team. And it's all these things coming together. I have overlooked the renal physicians as well, supporting the kidneys. And I think the summary is that this is a case which is a tribute to modern medicine and multidisciplinary management.
Thank you, Dr. Eyre.
I think this is a really great example of how endocarditis is not a single disease. And since it really is a multi-organ disease, it requires the team approach as mentioned. When I first saw the chest x-ray, my reaction was, this is not compatible with life. I've never seen a chest x-ray look like that. And I think it is a real tribute to the team that this young woman survived.
Julia, can you show the chest x-ray now? I think it
Yes,
was
Dr.
the slide that you, yeah.
So that's her ECG and the X-ray 6 weeks later.
It's amazing.
Beautiful, beautiful.
Michael, you really believe on surgery, isn't it?
Well, I think that the other lesson takeaway here is you mentioned risk averse behavior in the modern surgeon and in the modern care team, and you always get concerned about futility. And I think this is a major lesson, despite the fact how this chest X-ray look and the septic situation this patient came into, that a life was saved here because of excellent care and because people didn't throw up their hands and say, this is a futile situation. We're going to do everything we can to save this person's life.
Fantastic. So Julia, I guess the question now, yeah, this is a very interesting 19-year-old, so future pregnancy. I can actually answer one question here, is antibiotic prophylaxis. I just had to review all of these for JACC, for the journal. And it seems that in a patient like this, really antibiotic prophylaxis, we are talking about pregnancy and non-pregnancy. If you have any foreign material, in this case, a surgical material that is foreign, this is indication number one. And indication number two is previous infective endocarditis. So I say, if somebody asked me the question about this particular case, I would say, well, I'm not sure whether we have foreign material there in the repair of this patient. But certainly this previous infective endocarditis, and I think this this is very, very clear, two indications for infective endocarditis prophylaxis. The question is when? Anything. I would say dental procedure at the time of delivery and so forth. Dr. Prendergast, I am wrong or I am right?
Well, I think it always is an individualized decision, importantly, but the guidelines would support your conclusion that she is a candidate for prophylaxis, but only at the time of invasive dental procedures. The current guidelines, both sides of the Atlantic, would not include pregnancy or normal delivery.
Interesting. There are other issues here, and I'd like to comment about pregnancy in general. Dr. Erb, would you be concerned about this particular patient in terms of pregnancy in any way?
I really would not. She was left with normal valvular function, and consequently, I would not put her in a high-risk group.
Okay, so, and maybe Chandra, what did you learn in this case, aside of a great team effort, which I think has been emphasized, and there's no question, right, is the obvious?
Right. So it reinforced the early echo philosophy that all of us have. But one thing that is striking is, although we all say that the surgeon would go and operate, at least in the day-to-day practice, it sometimes becomes a battle convincing the surgeon to do it immediately. He says, give me 24 hours, stabilize the patient. And this is an everyday battle. So here is a good example of why we should be a little more persistent with the surgeon and say, look, I'm uncomfortable sitting on such a patient, and I know 2 days of antibiotics and stabilization may help you, but we may lose the patient. So it just teaches me to be a little more persistent about this.
I tend to agree. One of the challenges is how you move very, very fast, as Dr. Prendergast mentioned before, and to convince the surgeons that waiting doesn't lead anywhere. Michael?
So, you know, the philosophy, you know, used to be get as much antibiotics on board as possible and try to get things stabilized or sterilized as much as possible ahead of time. But you may remember, Dr. Fuster, we published that paper last summer in JACC that looked at surgical specimens. And with Staphylococcus and with Enterococcus, despite, it didn't matter how long you treated with antibiotics, anywhere from 3 days to 21 days ahead of time, the specimen still had a high degree of culture positivity, so that you're not gaining anything by trying to get more antibiotics on board. If they've got an indication for surgery, like we've alluded to here, press on with surgery. More antibiotics are not going to help.
Well, thank you very much. We have 2 minutes left. 1 minute is for Dr. Herb, and the other minute is for Julia. So let's conclude with the 2 statements.
I think I'll reiterate the fact that this is a terrific example of the complexity of endocarditis. It also highlights the fact that 70% of endocarditis is caused by gram-positive cocci, the most common of which is Staphylococcus, which also happens to be the most destructive. This case really demonstrates what Staph aureus endocarditis can do. Huge bulky vegetations, myocardial destruction, and overwhelming systemic illness. Again, I think it emphasizes the importance of a team approach and a very aggressive approach. Thank you very much, Dr. Herb. Julia?
From my side, Dr. Fuster, just to mention that as we said, that was a multidisciplinary approach to acknowledge the surgeon, of course, Dr. Christopher Blouth, the microbiologist, Dr. John Klein, the intensivist, Dr. Luigi Camporota, Professor Prendergast, and all the valve team and endocarditis team that they were involved in this patient's care. Actually, I will see her next week. I know that she's very happy and she's delighted, and she already thinks about pregnancy and how to live a normal life.
Well, thank you very much. I'd like to finish by saying, first of all, thanks to the American College of Cardiology for giving us the opportunity to start with this series of pathways very much related to patient care. And I'd like to give thanks, of course, Chandra, Michael, Bernard, Blair, and you, Julia, for the tremendous amount of work to put this case together, and also to congratulate your hospital and your staff for a fantastic case. It's a real example. Anyway, thank you very much to everybody, and I hope we can get together on another pathway. Thank you.